Their difference is that the principal investigator, Dr. Emma Burke from University of Louisville in Kentucky, did intensive pharmacologic therapy. In particular, they used an ACE inhibitor, an angiotensin receptor blocker, a high dose of beta blockers, aldosterone antagonist, and digoxin, all 5 of these medications. We started a very large multi-center study looking at recovery in LVADs. And our results were quite different. This was called the recovery study. This was, I was a principal investigator at the University of Pittsburgh with Robert Kormos. And we actually enrolled 212 patients. And when everything was said and done, our recovery to explant, that means you could take the pump out, was only 3%. We did not have a standardized pharmacologic therapy as part of the protocol. If I can frame this in a bigger picture, there's a large registry called INTERMAX that has 15,000 LVAD patients in the registry, and the recovery to explant was only 1.3%. So this is a really new finding, and we're all really excited about it in the LVAD, LV recovery field. These were presented as intermediate results. And the reason is because they really don't have follow-up. They have the recovery ejection fraction I saw was 55%, which is a normal heart. The question is, will these patients now continue to do well, or will they have recurrent heart failure? In our study, the RECOVER study, we identified LV recovery in about a quarter of the patients, but there's a great deal of fear with the clinicians to take the pump out. It's a very intense kind of clinical, sometimes emotional decision with the patients. They consider this their crutch, and they don't want to take it out because it's not easily put back in. It is a legitimate concern. And I think this study has the potential to really change attitudes that this can be done with intensive pharmacologic therapy.